It's really a paediatric flavour for the first hour, and the first speaker is Peter Gillett, who is a consultant paediatric gastroenterologist from Edinburgh, who is trained both in Newcastle and Edinburgh and Canada. He has a long-standing research interest in celiac disease, and he's going to give really a flavour of his own personal experience and research. Peter, thank you.
Thanks very much, David, and thanks to Coeliac UK for not only their sponsorship of this work, but inviting me to spout off about it in a shameless, passionate way. An overview. What I'd like to give you a flavour of is a lot of information out there from various countries, but part of the work that Lois White, my Dr. White now, rather than Lisa White from Cardiff, did as part of her PhD project. She was a nutrition graduate from Queen Margaret University in Edinburgh and happened upon us to look after her PhD and recently defended it very successfully a couple of weeks ago. I want to tell you just about the trends that we've seen within our paediatric population in South East Scotland. Also tell you a little bit about a project that we did across Scotland itself to look at regional variation. Mention briefly about some of the studies that have been done in various other countries, UK and abroad, and then really just give a bit of free thinking really about where we are and some of the opportunities possibly to drill into some of the paediatric aspects and origins of celiac disease. So this is a little reminder of what Scotland looks like. Alex Salmon's vision of a free-floating economy, awash with 30 years worth of oil, and our future to be decided sometime in September. Scotland, for GI purposes in paediatrics, is divided into three areas. A very large geographical area that is the north, with tertiary centres in Tayside Children's Hospital, Royal Aberdeen Children's Hospital, and in fact Raigmore Hospital in Inverness around this area. So that's part of the northern network. The network I work in is in this urban sprawl that is closely moving together to meld into David Sanders' alma mater, Glasgow, and the place I work in, Edinburgh. So we have our service covers Edinburgh, Fife, Lothians, Borders, Fife, and Glasgow. The Royal Hospital for Sick Children in York Hill covers a much larger population base in the west. So these are the papers that came from the sponsorship from Coeliac UK, and I'm going to tell you a little bit about both of them. They were both published last year, one in paediatrics, which is our 20-year overview of our experience, and then a year's snapshot at incidence, which threw up some very interesting data. So I'm going to tell you about my collaborators as I go on, because I'm going to forget at the end probably. So Lois and Victoria Merrick. Lois, who, as I say, did this as part of her PhD. Victoria, one of our registrars. Elaine Bannerman, Senior Lecturer in Dietetics at the Queen Margaret University in Edinburgh. Richard Russell, now GI Consultant in Glasgow. Darren Basudi, Consultant GI Paediatrician in Bristol. Paul, one of our current trainees, Dave Wilson, who's my long-term colleague and collaborator, and I did a little bit of this work too. So what we did, looking at 20 years worth, was to do a literature review of all the longitudinal incidence studies to compare. We looked at 20 years of European and North American studies, which have generally shown an increase in incidence within the paediatric population. As antibody testing and strategies have become honed, we've done more and more targeted screening. We've seen more and more monosymptomatology or non-classical symptoms and a general drift upwards in age at diagnosis. And most papers would suggest that the rise in incidence is due to a lower threshold to test, which I'm sure is correct, although a few studies, including a couple from Finland, would suggest that there is a true rise, and postulated, as Derek Jewell asked earlier on, regarding the hygiene hypothesis and autoimmunity. So it was actually Joe West's old boss, Richard Logan, who last published something from Edinburgh when he was with Anne Ferguson in 1979, and there's been a dearth of information from our area since this paper, until this paper came out. So when we did the study at that point, there had been no previous specific study in our area, and certainly within Scotland, to look at this in such depth. And we aim to look at incidence between 1990 and 2009, age at diagnosis, reasons for diagnosis, and what classical presentations or active screening took place, and then the non-classicals. And as a bolt-on, we looked at the most recent laboratory results for newly diagnosed patients in the last 5 years. So we performed case note review, pathology database, endoscopy and electronic patient records. And as luck would have it, all the under 16-year-olds only get biopsied in one centre, and that's ours. And it would be unusual for us to actually miss anyone more recently for various reasons. We looked at all children under the age of 16 who were biopsy proven between those time points, and looked for the whole of the region. And we looked at serology, which clearly over a 20-year period had gone from something that was a bit rubbish to something that was much more robust and reproducible. Demographics, reason for diagnosis, and these blood tests. And we defined initially as classical celiac disease being 2 or more GI symptoms, or 1 GI symptom and an additional commonly noted symptom that would fit with celiac disease. Non-classical was either monosymptomatic or an extra-intestinal indicator. And active screening defined as diagnosed primarily because of an at-risk condition or a family history in a first-degree relative. During the study, the Oslo definitions came out. So in fact, what we did was we bolted on some further work looking at Oslo classical presentation, and we looked at multiple deprivation and urban-rural classifications too. Now, we rather grandly called these 5-year time periods epochs because we like that sort of thing. We like to big it up in Scotland. I guess we should have maybe called them quintiles or quintennia to be more accurate, but we got away with calling them epochs, and the American publishers seem to like that kind of thing. So we looked at incidence rates per 100,000, age and sex standardised to the midpoint 2001 census data, and we looked at comparing these models to look at incidence rates between these different time frames. And what we noticed was this is a number of cases per 100,000, and its incidence in the beginning of my paediatric career, which started in 1990 when I was doing capsule biopsies on Ward 5 at sick kids. We diagnosed 1.6 per 100,000. And this has gradually clearly gone up with the advent of probably good serology and more awareness to 11.8 per 100,000. Clearly, we're still missing a large number if serological prevalence is to be believed. So when we look at percentages of increase, in total cases we've gone up by 6.5-fold really. And if we look at the Oslo definition of true classical cases, we've actually had a rise of nearly 3 and a bit fold. We've clearly happened upon screening over the last 20 years, and that obviously does account for a large number of cases. But we've actually seen that the number of classical presentations has actually remained fairly constant. This is a chart showing the median age at diagnosis going from 26 months up to 90, I believe, over these different time periods. So what we've seen is a greater proportion way back then of under 2-year-olds, but the numbers have gone up as we've tested more. The classical cases, they are definitely younger with a median age of 61 months compared to non-classical or screen groups, which have a median age of 109 months. If we look again at classical cases, In Epoch 1, the median age at diagnosis was 26 months. We're now looking at 81 months in that classical group. Male to female ratio, much as you'd expect, nearly 1 to 2. And as was mentioned earlier, that in our survey there was really no difference in urban, rural, or in social class when we looked at incidence. When we look at symptoms, the classic symptoms, diarrhea, abdominal pain, fatigue, weight loss, and abdominal distension. Just under 10% were asymptomatic, and the majority of those were due to type 1 diabetes, a third due to family history, and a smaller number due to children that were actively screened with Down syndrome. When we look at blood work parameters, there was no difference between males and females, and the usual rules apply. It was a low ferritin, even in the face of a normal haemoglobin. It was anemia, low MCV, lowish folate, and a slightly low albumin in a large number. So what we feel we showed was that we showed there was a significant increase in incidence. We felt that was partly attributed to better awareness, certainly more active screening, and more awareness of subtle presentations. And we looked at a definite true rise in classical presentation, which the way we worked this out was that we teased out the fact that there were more children being diagnosed with classical presentation even now. So the shift hasn't changed as much as other studies might have suggested. So we felt that there was a true rise, and that's obviously with the rider that we're clearly not diagnosing 1 in 100, but this is actively looking for children on the basis of symptoms and screening at-risk groups. So over the last 50 years, why could that be? Why is there an increase? Well, lots of hypotheses. Can't be due to human genetics alone. We have an extremely stable population in our area. It's presumably part of infant feeding practice. We mentioned the hygiene hypothesis. Mode of delivery has been mentioned. Clearly antibiotic use, more antigenic wheat being processed. And we feel, I think as a lot of people do, that there's a huge amount of work needs to be done within the younger population to find out what combination of factors, including the microbiome, needs to be teased out to tell us why this increase in actual presentation is happening. We feel that there is better awareness. In fact, the other study I'm going to show you shows you that there are more tests done in GP practice within our area. We're certainly seeing a significant number of classical children, but an increase in older children as well that are being diagnosed. So we felt this was relatively novel, and there's certainly a Finnish study that would suggest this too. So going on to the next study that we did, what about geographical differences within Scotland? We're a small part of a population after all. And this is a project that was done by Lois, but with collaboration from a number of individuals, extra people involved. Elsie Carnegie, who's a dietitian from the Royal Aberdeen Children's Hospital, Dagmar Kastner, who's a paediatrician in Tayside, and Porrick McGrogan, who's a fellow GI consultant in Glasgow. So this was done through the Scottish Paediatric Society, which is actually an extremely long-lived organisation, and an email system was set up within members of the SPS to have a monthly, almost like the BPSU emails that are happening now, and a number of projects were on the go. We wanted to try and mimic what was available in Sweden and the Netherlands, but clearly they're way ahead of us, having a national register of patients, and very robust information comes from that. So we kind of road tested an email project. Again, Scottish population and the way it's broken down. Thankfully, it's much easier to do this in paediatrics because children were scoped in one of really 4 places. Aberdeen, Inverness, Dundee, or in Edinburgh or Glasgow. So we actually were able to capture the people that were doing these tests to do a capture-recapture type design. So what happened was we had a questionnaire that was ethically approved. We were allowed to have age and sex in the questionnaire. We had first part of postcode, and it was felt to be anonymised enough that we could get away without ethics approval, and it proved very helpful. So we looked at demographics, symptoms, associated conditions, blood tests performed, and biopsy details. And it was all approved and anonymised. So in fact, in August 2009, the email was set up, and there was a month's worth of run-in to allow people to get used to it. And then from September for a year, we did the project. A positive response came back to my email inbox, and then I sent the questionnaire out and then followed it up. Population-wise, South East Scotland and the northern area are very similar in population, and this is under 16-year-olds. The west of Scotland has double the number. And what we planned to do was we needed to have biopsy confirmation, so patients were excluded if they didn't get biopsied. We looked at incidence rates, and we did some statistics to try and look at any differences in nominal and continuous variables. So from our area, there were 45 forms, 60 from the west and 24 from the north. There were 16 cases of double reporting that got sifted out. Diagnoses before that beginning date were actually taken out as well, and there were 4 children not biopsied, so they were excluded. So at the end of the study, we actually had a similar number in the east and the west, with about half in the north. And that equates to double the incidence in our area. So 16.3 per 100,000, 8.1 and 7.7. And when we drilled into the detail, that clearly gives you double the number that we're actually diagnosing. Male to female ratio similar median age, no differences in gender ratios, and no real difference in median age. So we thought this was quite interesting. The most common symptoms, very much like our 20-year study: abdominal pain, poor weight gain or weight loss, fatigue, diarrhea, bloating, but a slightly higher number that were asymptomatic at 14.3. And all these asymptomatic patients were diagnosed through active screening, predominantly type 1 diabetes or family history. And when we looked at the patients with classical, non-classical and actively screened patients, we saw that there was more active screening done in our area than in other areas, and that really fitted in with the fact that we were testing more generally. Just to reassure, we most of the time had a diagnosis done in a paediatric setting. There was one adult gastroenterologist involved in the west, and some paediatric surgeons actually who were doing endoscopy in Inverness at that time. So they were mostly diagnosed in a paediatric setting. To try and kind of capture what an underlying reason might be, we actually looked at the number of requests for celiac serology, and we found that in our area there were nearly 3,000. Remember, we've got half the population of the west of Scotland. So 3712 from the west, which represents 7.4 in 1,000 being tested compared to our 12.3, and in the north a very similar number. So we were testing significantly more, and significantly more actually came from GP in our area than the west. We didn't really get the data from the north, and in fact, although we had planned to achieve that, we didn't. So we were getting more tests done through primary care, whether that was because they were being advised or they did it off their own bat. To me, it probably is important, but it's interesting we were testing more. So, in summary, first study, see there's the Scottish, but national incidence. Age at diagnosis, really very similar throughout, but we had double the incidence. And it can't really be due to population genetics because it's all very, very similar wherever you go in our country. Maybe better awareness, lower threshold to test, and then we had planned to get more information but didn't manage that. Okay, so that's Scotland. What about other countries within UK and Europe and North America, just very briefly? Well, I thought because the chairman's from the Yorkshire area now that we would, the kingdom, my wife's a Yorkshire woman, so I thought I'd put it in because of that too, David. So, I mean, you're seeing this in the adult population. I guess you're diagnosing more as well. Changing demographics. Colleagues, paediatric colleagues in Cardiff seeing a very similar trend overall. And in fact, interestingly, from the Welsh cohort, 36% of their new patients come from active screening compared to 23-point-something%. So very much more actively screened patients in certain areas, but the trend is very similar. So Finland reports very similar, Sweden also very similar reports of increasing but fluctuating levels and trends. So what about the big debate? Again, towards the chairman's publications, you know, the sycophantic bit that you always have to do. So the big debate, well, David Sanders asked two questions actually, very similar time frame. Are we diagnosing too many people? Well, no, not really, are we? We're not diagnosing enough. We're not capturing all the ones we should. And is it time to screen? Well, I'm probably in your camp as well. I don't really think that we should be screening the general population. I think my personal experience is a bad one in some respects when you actually can't give a family a proper diagnosis despite looking very hard and leaving them potentially with a question. So I think active screening very much on the cards, but trying to get more aggressive with it. So in conclusion, I guess case finding does work. I guess in our area, we're much more aggressive, I think, with trying to promote education. We set up probably 6 years ago now due to Dennis Norden would call it a cock-up. We rely on paper copies of results coming back. I have a colleague who did a celiac screen on a 3 or 4 year old girl, and unfortunately someone very helpfully filed it away in the notes without him seeing. And 6 months went by, and the patient then pitched up saying, well, actually, what were the results? What was going on? In fact, 6 month delay, and there was a big complaint about it in our area. So what we did to try to improve things was, now, we diagnose maybe 40 or 50 patients a year within our region. I get emailed by the laboratory that does the test with every new positive result, and actively manage them from there. So it's often me going back to the GP or writing to the GP saying, hey, this test's positive, what are we going to do about it? Rather than having potential patients lost. Now, it's a bit of work, but I guess it does, I think, nail as best we can getting a good diagnosis on these patients. And that's maybe what we do compared to the other areas, maybe a bit more aggressively. So our local approach may be better and more aggressive at getting patients in through the doors. The thing that really interests me is this increasing wealth of genetics information, the microbiome work, infection, what influence antibiotics or other drugs might have, and the infant feeding questions that we're hopefully going to get some answers from the big European study that's, I think, probably now about to finish its recruitment, but nothing out there much yet from final data analysis. I guess the important thing for me as a clinician is ensuring that the diagnosis remains robust, and that's obviously hanging on some potential new changes within the paediatric community. I guess this is probably dreaming, but maybe collaborative big centres within the UK to get better epidemiology and maybe collaborate to answer some of these big questions. And a national study, certainly within Scotland, is possible, and whether it's possible on a UK-wide basis, I think, is maybe logistically and financially more difficult. So I've got two main sponsors that I want to thank. We could not have done any of this work, and Lois could not have got her PhD successfully without the help of an endowment locally that came through Coeliac UK, and 2/3 of her finance from Anne Gloag and her family foundation, the Stagecoach founder. And we're very grateful to everyone who helped and all of our collaborators. So I'd welcome any questions.
Questions from the floor? Peter, can I start you off with a question?
Yeah.
Coeliac UK make a joke and say that if they look at their membership, it's clustered around all the groups that are interested in celiac disease. So is it that actually you've just infused the whole of Lothian into testing?
Modesty aside, I'd like to think so. I think all of us who are in this room are very passionate about making sure people get diagnosed earlier, get to see the right people who are dietitians. More of them, please. And for follow-up to happen, and for them to get good quality advice rather than some of the, dare I say, rubbish that they get told before they come and see people that know what they're talking about.
So if we take that a step further,
say that.
Yeah. Now, how do you get other people to come on board? One of my sisters is a GP, and she said to me, if this was on the QOF,
yeah,
everybody would. You'd test them when they walk through the door, you'd test them on the way out the door, and you'd test them before they even made their appointment. And that is the difficulty, isn't it, with this? What would you say? How would you get people from Glasgow to test?
I think it's really difficult. I mean, my colleagues in Glasgow have a fantastic dietitian-led service. Elaine Buchanan is actually doing the model that you've got, and our colleagues from Somerset would like to have or are about to have. So it's not that people aren't out there passionate about it. I think it's really difficult. Education, you can put everything, every bit of information out there. You can trickle it out there through GP talks, parent groups. I think it's really difficult. It's sometimes very frustrating when you put so much effort in. So I don't know. I think putting it through a QOF framework, I think, is a very, very... I'd like to add constipation and childhood onto that as well, because it's a huge amount of my work too. I don't think certainly the political will in Scotland is there to do it. I think the GPs would like to. They'd like to be paid for it. If they're not paid for it, then I can understand why they really don't want to really play a hugely active part in it. Very controversial, actually, but I think we should continue to look into it.
Any other questions from the floor? Please introduce yourself.
Nick Kennedy from Dublin. I work in St James's Hospital and a celiac clinic there, and I'm president of the Celiac Society in Ireland. I wanted to know, in your effort to enthuse your locals about picking up celiac disease, what are your views on the use of point-of-care tests, and do your pharmacists want to screen for celiac disease using those?
Well, the man to my left is probably the person to answer point-of-care testing issues, but it certainly we don't have a lot of families coming from GP referrals having had a point-of-care test, and that's all. In fact, my memory is really in the last year or two that we've not really had anyone. The only person was probably, she would have been about 3 years ago, one of my colleagues who's a paediatrician who works in A&E at sick kids. His sister, they were on a family holiday. She's married to an Italian. And they were on a family holiday in Italy, and he hadn't seen his niece for a while and said, that pot belly and wasted bottom equals celiac disease. And she was the only patient I can remember who had a point of care test. But they then went to the GP and got it done. So it's not something I have a lot of experience with. I've used some of them in a trial basis way back, but it's not something that we would actively encourage because we have very, very easy access for GPs to a phlebotomy service in our hospital. So that maybe breaks down the barrier of being tested.
I can give you my view. I mean, obviously, I have to declare conflict of interest because I'm undertaking some research in this field. I think the point of care tests are coming or are here, and they're not going to go away. And people are desperate, and there's a delay in diagnosis. So there's an unmet need there. Last year at the British Society of Gastroenterology, they set up a booth and said, all those who wish to be tested, please enter. And more than 150 people rocked up and were tested. And there were, I think, 14 positive cases. So why did those people never see their GPs or get tested? Or I have no idea. I didn't believe it would work. I thought it was a hoot at the time. And then I had to laugh on the other side of my face. Okay, and it was nursing staff from our unit that were running that for Tillot's. So I think there's an unmet need, and I think I can see a role for point of care tests, but I think we need more work to be done to validate them. I have had some ethical thoughts about what if you go into a pharmacist and suddenly you're collared and asked, do you want to be tested for this? What are the ethics of that? And I personally ran a screening study of 1,200 healthy volunteers 10 or 15 years ago, so I know what that feels like. But these people, if it's done in the context of research and they go in and they have symptoms and are buying things over the counter for gastrointestinal symptoms and have not been tested for celiac disease, maybe this is a means of filling that gap in, if I was being controversial, I'd say a sea of nihilism towards celiac disease by many in terms of making the diagnosis. But I am conflicted. Okay, Peter, thank you so much.